So today we're talking about risk factors for breast cancer and also risk assessment and screening. It's always a good idea to review what are the characteristics that can make a woman at higher risk for breast cancer. And certainly we recognize that breast cancer is very rare in males. For every 100 women with breast cancer, there is one man. So being a woman is a risk for breast cancer. And also getting older increases the risk. People who have themselves had breast cancer once are at risk to develop breast cancer again. And there's also a big role for family history and for genetic predisposition. And we're going to talk much more about that over the next few slides. Also, there are conditions that some women have that can be diagnosed if they've had any surgery or biopsy of the breast, and these conditions increase their risk. They indicate that the woman is at increased risk for breast cancer. These are called atypical hyperplasias and LCIS. So these are conditions that women may have that can show that they are at increased risk. There are also...
Since the OBGYN here, I asked her about the typical hyperplasia. 東京先生、ちょっと日本語で日本語にはいたしましたけど、何のことか全く多分普通の人はわからないので、この症状について。
We're talking simply about the breast.
Yeah.
Breast, yeah. So,
ご説明いただければ、日本語でお願いします。
がんの細胞っていうのは、ステージ上の細胞からが異常ちょっと変化していって、がんになるんですけど、そのがんとノーマルな普通の細胞の間ぐらいですか。なんかちょっとアブノーマル、普通じゃないけど、がんとまでは言えない。
Thank you very much.
Okay, sorry, so we're going to continue. There are some other risk factors for breast cancer that have to do with reproductive factors. So having a very early first menstrual period before age 12, late menopause, having had children later in life, and taking combination estrogen and progesterone hormone therapy after the usual age for menopause can increase the risk for breast cancer. Women who have had any kind of radiation treatment to the chest, this is not about x-rays, this is about women who've been treated for other cancers with radiation in the chest area, are also...
X-ray ではありません。他のがんで胸部を放射線を当てた方という意味です。
And then there are some lifestyle factors like obesity, cigarette smoking, and alcohol use that also can increase risk.
最後、アルコールになってます。アルコールです。すいません。
So I want to talk a little bit more about family history in more detail. So women who have close relatives with breast cancer, close relatives are parents, siblings, brothers and sisters, and children are at increased risk to develop breast cancer. The closer the relative, the higher the risk, and the younger the relative, the higher the risk. So that's a kind of a simple summary of that. In some families, this isn't common, but in some families, there may be a genetic inherited susceptibility to breast cancer. This is a minority of breast cancer, maybe 5 or 10% of breast cancer is because of these abnormal genes. And these families where it is a genetic risk for breast cancer, what you see, the pattern, is generation after generation of women with breast cancer, women affected when they are young with the disease. You have more often situations where women get cancer in both breasts. And in these families, you can also see more other types of cancers as well, not just breast cancer, but other kinds of cancers, and especially ovarian cancer can be seen in these families.
特に卵巣がん なりやすいということですね。最後の他のがんになる可能性が高い部分ですが、特に卵巣がんということです。
So in these families, if we're looking at a family history and it appears that there is a very significant chance that the reason for all these women to be affected with breast cancer is because of an abnormal gene, again, we see multiple generations, women affected young, more women with cancer in both breasts. When we see ovarian cancer in a family where there's a lot of breast cancer, that's a big red flag that there may be a genetic reason for that. Especially if you see in one woman breast and ovarian cancer, that strongly suggests there may be a genetic component. Certain ethnic groups are more likely to have these predisposition genes, especially Eastern European Jewish people. And another big signal is if there is breast cancer in a male in the family. That also is a red flag, a warning that maybe there is a genetic reason for all of this cancer to be happening in the family.
これちょっといろいろ日本語が書いてますけれども、一番は若くして乳がんになったり、両側という言い方を日本語ではしますけど、両側に乳がんがなったりする家族の方、もしくは乳がんが何人かいて突然一人だけオベリアンキャンサー、卵巣がんがいたりすると危ないですねと先生はおっしゃってます。そして一人の女性が乳がんにも卵巣がんにもなるというのも家族性がすごく疑われる。私たちはもしかして関係ないんですけど、東ヨーロッパ系のユダヤ人だとか、家族に一人でも男性の乳がんがいらっしゃると、それもかなり家族性が疑われる率が高いと。
Now, in these families, when there is a genetic reason for the increased risk of breast cancer, they're inherited from, this abnormal gene is inherited from parent to child. This is called autosomal dominant. It has to be inherited from a parent to a child, but it can be inherited from either the father or the mother. It doesn't just have to come from the mother.
いつも乳がんというと女性と疑われますけれども、これは、家族性の乳がんの場合はお父さんからも遺伝が来ますので、お母さんからだけでは決してないです。
Now, when we try to investigate a family, if the family looks like there's a tremendous amount of breast cancer and it follows the pattern that we just spoke about, the way to investigate is to first do testing on someone who has had the cancer. That's the best way to start. They're the most likely to have the abnormal gene if that's what's happening in the family.
一番初めに検査するべき方は、なったという記憶だけではなくて、今なっている家族の方が遺伝子検査をするのがスタートとして一番好まれます。
And the genetic testing can be done on either a blood sample or a sample from saliva.
血液からも唾液からも今は遺伝子検査ができるそうです。
So the first two genes that were discovered that seem to be responsible to increase the risk for breast cancer in families are called BRCA1 and BRCA2.
今一番初めでみんな、私のように乳がんというのはみんなが知っているのはBRCA1、BRCA2 という英語の発音の仕方をする遺伝子です。
Women who have these abnormal genes are at higher risk for breast cancer and ovarian cancer, and men who have these abnormal genes are at risk for prostate cancer that can happen at an early age. And in the BRCA2 gene, we also see male breast cancers in those families. That's a very rare occurrence. Also, people who have mutations in the BRCA2 or BRCA2 gene are at increased risk for pancreatic cancer and possibly melanoma. Okay. Now, to give some more specific risk estimates, women who have a mutation in BRCA1 have somewhere between a 50 and 85% lifetime risk for developing breast cancer. That's a big, huge number. They also have a 40% risk at least of developing ovarian cancer, again, very big increase. And there is a particular type of breast cancer that is more frequently seen in these individuals, and that's called triple negative. So not only did it increase the risk to get breast cancer, but it increases their risk for a very particular type of breast cancer.
このBRCA1というのは一番みんなが検査するものですけれども、この遺伝子を持つ方は50% から 80% の確率で一生涯の中で乳がんに罹患すると言われております。で最後の、一番のBRCA1でこのBRCA1の遺伝子になる方はトリプルネガティブで治療がしにくい乳がんになる確率がとても高いそうです。
Women who are BRCA2 carriers also have a high risk for breast cancer, although it's a little bit lower than BRCA1. And the risk of ovarian cancer, again, is much higher than typical people, but maybe a little bit lower than BRCA1. Women with this genetic mutation get the same kinds of breast cancers that women with no family history and no genetic abnormality will get. The same type of cancer, not a specific subtype.
BRCA2 という遺伝子を持つ方は少しBRCA1より低いですけれども 40% から 60% を一生涯の中に乳がんになるそうです。しかしこれちょっと違うのはこの遺伝子を持って乳がんになる方は特別なサブタイプとない前の1だと難しいタイプの乳がんになるんですけれどもこれはそれとは関係ないということでした。
Now, we said that BRCA1 and BRCA2 were the first genes that we found could increase someone's risk for breast cancer, but since that time, there are a number of other genes that have been discovered that can increase the risk for breast cancer, and I listed a few of them here. So, the first one here, PALB2, is a gene that is associated with an increased risk for breast cancer and pancreatic cancer, and it functions in the DNA a little bit like BRCA2. TP53, when that gene is mutated, people are at increased risk for many different kinds of cancers, and the key element in that genetic mutation, which is very rare, the key element is that they can get cancer at a very young age, and they are recommended to start screening in their 20s. P10 is also associated not just with breast cancer, but also thyroid cancer, which is actually pretty common in women. And CHEK and ATM are two genes that are much less common. They're pretty rare in the general population. ATM is associated with many different cancers, breast among them, and CHEK the same. The risks are lower. With all of these genes, the risks for breast cancer are lower than with BRCA1 and BRCA2.
この5つの新しいBRCA1、BRCA2 以外の遺伝子はこのを持っていても乳がんになる一生涯の確率はかなり低いそうです。
Now, in the past, when women did genetic testing, we only tested for the genes that we knew, BRCA1 and BRCA2. But today, when women do the genetic testing, whether the blood or the saliva, they can be tested for a panel of at least 30 genes that we know about now that may have a role in increasing many different kinds of cancer. Breast cancer is one of them.
最近まではBRCA1、BRCA2 しか乳がんの検査、遺伝子検査はなかったですが、最近は31種類以上の遺伝子検査をすることができるようになりました。
When we do genetic testing, the results can show a mutation, and a mutation means that the gene is very abnormal, and this clearly results in an increased risk for the disease. When someone is found to have a mutation, it results in some action. There's something that we do about that. We change the screening, we offer some prevention intervention. It should result in some kind of specific action that's taken because of that test result.
遺伝子検査をすることの一番の理由は下の方になりますけれども、それを知ることによってそれぞれの遺伝子検査をなさった女性の遺伝子の突然変異を探すことによってスクリーニングをいかにうまく使ってそれを乳がんになることを防ぐことができるというのが一番の目的です。
Now, in the past, we recommended genetic testing mostly for women who had a strong family history for breast cancer or other cancers. But today, sometimes we also recommend genetic testing if the cancer is of a particular type. So, for example, a young woman with breast cancer that is that triple negative type that we spoke about a few minutes ago may be recommended to do genetic testing even if there's no family history of the disease.
サマライズしますと、今までは家族性があるような方だけを問診によって家族性があるような方だけに遺伝子検査を進めていましたが、今は60歳以下の女性でトリプルネガティブというタイプの乳がんになった方は、家族のためにするようにと勧められています。
Also today, we are getting to the point where the treatment of a cancer, if it happens, may also be influenced or changed if the person carries one of those mutations. And the example in breast cancer is that there's a special class of drugs called PARP inhibitors that really are only effective for women who are BRCA mutation carriers.
最近では遺伝子検査をして元々のガイドラインにあるがん治療を少し変えることもあります。例えば、パープ阻害薬という乳がんの治療法があるんですけれど、それをする場合はBRCAの遺伝子を持っている人にはとても効き目があるということが分かっているからです。
Now, women may have more than one kind of risk factor. They might have family history, they might have other issues, and a person, when we look at a risk assessment for an individual, we have to take all of their different risks into consideration to think about what their lifetime risk for getting breast cancer may be. Okay. So the reasons that we think about this and that we do this assessment for breast cancer is really because it allows us to give people good information that will help us understand how their screening should be, when they should have mammograms, when should they start, how often, whether other treatments or screening methods are appropriate, and also to identify people that would benefit from particular risk reduction strategies. Knowing your risk as an individual woman is important so you can work with your doctor to create a screening program that is appropriate for you specifically. We know that screening for breast cancer can save lives because it gives us the opportunity to find the disease early if it should happen, and to give people better outcome of treatment and to allow them to have treatment that interferes less with the daily life.
なぜ乳がんリスクを考えなくてはいけないかというページですが、罹患のリスクを知ることで担当医に十分なスクリーニングを考えてもらえる時間が与えられる。そして乳がんの適切なスクリーニングは確実に早期発見の比率を高めることが分かっています。それと最後に早期乳がんを発見すれば担当医、医師も治療をうまく進めていくことができるということがあります。
When we talk about screening for breast cancer, there are three parts. One is for women to just have some awareness themselves of their breasts and to notice a change if it happens. Two is breast examination by your doctor or whoever's taking care of you. And then the third is breast imaging, including mammography as appropriate. Mammography is still the only imaging modality for breast cancer that has been clearly shown to reduce mortality and save lives. This is still true today. The age when a woman should start mammography can be influenced based on her family history. If there's family history of women being diagnosed with breast cancer at a very young age, then that woman might need to start her mammography at a younger age as well.
今までの中でママグラムが一番ただ一つ死亡率を下げる映像にて早期発見をできるやり方だとおっしゃってます。で、初めてのママグラムの年齢は家族性のことを考えて乳がん歴、家族性乳がん歴を考えてそのベースを考えます。
When women have dense breasts, and this is particularly true in younger women, mammography is not as sensitive a test as we'd like it to be. In that case, there are other tests that can be added, particularly ultrasound can be very helpful for screening in women with dense breasts.
ママグラムの正確性はデンスブレストと英語で言われてますけど、高密度の高い乳房ほど良くないので、その場合は超音波を追加ですることが求められます。
Adding ultrasound helps find a few additional breast cancers when women have dense breasts. We also know that ultrasound can sometimes cause women to have biopsies that show things that are not cancer, that's called a false positive. But the benefit of ultrasound really is mostly in women with dense breasts, and that's where you have a better chance of finding something that's not seen on the mammogram.
デンスブレスト、高濃密度の乳房を持つ方の場合は、超音波をすると時々間違った結果も出てくるのですが、ママグラムと併用することで、7.2 に1000人に 7.2 人の乳がんの発見を 1.1 に下げることができるというふうに結果が出ています。
MRI is a test that can be used for screening very high-risk women. It also can be used for other things to help solve a problem that's seen on a mammogram that we don't know what it is, or looking at integrity of breast implants. But for screening purposes, MRI is really only for the highest risk women.
MRI のスクリーニングはとても高い遺伝子の可能性を持つ女性にしか用いることができません。それとインプラントをやってらっしゃる方はこれが使用可能だということです。
In a summary, I think it's very important for women to understand their risk for breast cancer. When there is a significant family history for the disease, genetic testing can clarify, can help understand a woman's risk to develop breast cancer. And today, we understand that there are many genes that people can inherit from parents that might increase their risk for breast cancer. When we make screening recommendations for women, those recommendations should be based on a woman's age, the density of her breasts, and her breast cancer risk when we assess it looking at all of those different risk factors that we spoke about.
サマリーといたしまして、家族性の乳がんがあると思われるときには遺伝子検査で乳がんリスクを明確にした方がいいと思います。そして現在ではがんに罹患を想定できる遺伝子検査の種類が広がりつつありますので、これは私のツイートですけど、保険も入っていることが多いです。それと最後に乳がんのスクリーニングは年齢や高密度の乳房、デンスブレス化、そして罹患のリスクによって決められるべきだと彼女は考えています。
Thank you. And if anyone has any questions.
もしご質問がございましたら手を挙げて立っていただいていいですか。ピンクのシャツの。
Thank you very much. Very important point. I was diagnosed dense tissue at some point 10 years ago, and since then I've been checking every 6 months. And during this time, I somehow changed doctor. Some doctors said you don't need to take any more. It will be okay. But if I change another doctor, he will start again taking tests. Dense tissue at some point. Is this more? Do I have to still keep checking? My family does not have history.
すいません、彼女の、質問はですね、デンスティッシュの、乳房だと言われてもう数年以上経ちます。10年経って6ヶ月ごと検査してましたら医者を変わりました。 医者に変わったらその先生はそんなの必要ないよって言われました。また変わったらどう言われるでしょうねっていうところがご質問でしょうか。
As women get older, typically, especially after menopause, the breasts do get less dense. And when the breasts get less dense, the ultrasound is less valuable. But I really want to point out to you that every time you have a mammogram, on that mammogram report, it's supposed to say something about density. So no matter what age you are, if your mammogram says you're still dense, then you probably should have an ultrasound.
だいたい年齢を伴ってデンシティっていうのは下がっていきます。ところが一回一回ママグラムをやるときに確実にあなたの乳房はデンスなのかデンスじゃないのかという報告がなされるべきなので、それを見れば次の機会に医者を変えると変える関係なく、その検査を続けるべきなのかが分かると思います。
Thank you.
I have two questions. One is related to what she said, is a dense breast. It's about my case too. Number two is about the polycystic breast, but no cancer and hoping not forever. But anyway, about dense breast. My question is actually insurance coverage. My GY didn't really recommend me, although mammograph said dense. I knew about it from like 2-3 years ago, but I haven't done sonogram yet. And then the other thing, the second question is related to American friend of mine who has actually a history, like her sister and then mother, high risk. But her question is actually for her, asking you is that mammography, it's not effective, we know that, but combining with other things, MRI is needed or not, what would be done, like her case?
ソノグラフィーのコンビネーション。彼女2つあって、初めのはピンクのスウェーターの方と同じなのでということ、2つはお友達が、ママグラムだけでは十分ではないので、他に追加でファイブの場合は他にノンジャストママグラムがあってね、2つ目の検査をすべきかどうかというご質問だというふうに理解いたしました。
Fibrocystic change in the breasts is very, very common, and maybe 50% of women who are before menopause, younger women, will have some fibrocystic change in the breast. The only patients who are at increased risk are the ones that have what we talked about, the atypical hyperplasia. Otherwise, most of fibrocystic is not an increased risk for breast cancer.
ファイブロシスティックというのは乳がんになる可能性に導くものではありません。一番重要なのは。
With dense breasts, there is a little bit of debate about what to do. And even though we recognize that it makes the mammogram less helpful, first thing is the mammogram is still important because even when the breasts are dense, you can find breast cancer. But what I think you were referring to is that sometimes we can say a woman should have an ultrasound and then the insurance will not pay for it. And that's a problem. It's like a disconnect between the two things. And unfortunately, I can't resolve it. But I think that to me, it doesn't make sense to tell a woman you should do a mammogram every year, but we know for you it's not the best test, and we wouldn't want to say don't do something else that could improve the situation. I think you probably know that many states now in the US, including New York, New Jersey, and Connecticut, require that when a woman is notified about her mammogram results that she has to be told if she has dense breasts. That's a law. So if it's a law, what would they like us to do with the information? Exactly. Yeah.
高密度のデンスブレストを持っていらっしゃる方はママグラムだけでは早期発見をしにくいので、追加に今本の中にありましたようにウルトラサウンドをやることは求められます。で、今コネチカット、ニューヨーク、ニュージャージー州では デンスブレストを持っている場合はそのように結果に書かないとダメなので、ほとんどの場合は保険が効くべきですが、そうじゃない場合もありますねということでした。他にございますか？じゃあどうぞ。はい。
Thank you for sharing the information. My question is how to get the genetic test and then insurance is covered, generally speaking, and then maybe second question is my mom has ovarian cancer and she passed away, and my OBGYN doctor knows, but he never recommended me to take the test. So how should I?
お母様がダウン双眼でお亡くなりになっているという家族歴があり、その時に検査は遺伝子検査はしていないということですね。で、質問はそれで。
質問は、
保険をカバー
保険カバーしてテストを
保険をカバー、あなたの場合、ご本人が保険をカバーできるのかどうかという質問。
あと私の先生は私にテストを受けろって言ったことがないんですよ。それは
どんな先生ですか？
私の婦人科の先生です。
How old was your mother when she had the ovarian cancer?
64.
64歳の時にお母様が卵巣がんで亡くなられて、今彼女の今来てらっしゃる方の、先生産婦人科は、遺伝子検査を受けるといったことがないとおっしゃっています。
So I think we learn more about genetics all the time. And years ago, I don't think they were as sensitive to the idea of genetics as we are now. And it's possible that when your mom was sick and passed away, that wasn't something that was very high on everyone's list at that time. So I can totally understand because things have changed. And I will tell you as an aside, there's actually a movement now, and maybe you'll hear a little bit more about this later, that every woman with ovarian cancer should have genetic testing. Every woman who's diagnosed with ovarian cancer below the age of 70, regardless of family history, should have genetic testing. And there's actually a big movement in GYN oncologists now to do this. In terms of you, the way to be tested, I think there are a couple of routes, a couple of ways to do it. Many GYNs will do the testing in their own offices. They've gone through some training, they have a relationship with the various genetic testing companies, and that's one way to do it. Another way to do it, which I recommend a lot when women have complicated family histories, is to go with a genetic counselor. Almost all cancer centers will have cancer genetic counselors who will sit, will go over the whole family history with you, will talk about the testing, and whether you do it in your OBGYN office or you do it with the genetic counselor, they are very careful to make sure of whether or not it will be covered by your insurance. And I'm going to add one more thing. I'm going to add one more thing because this is important. I know it's a long answer. One more thing. Because this is really important and really positive thing to say. The technology has evolved so rapidly that genetic testing today, if someone asked you to pay for it with your checkbook, could be as low as $250 or $350. So it's not the way that it used to be. And there's going to be a time, and it's not very far from now, where it's going to be, the cost level will be so low that that will not be an obstacle anymore.
初めの方の質問に行きますと、なぜ婦人科はいろいろ検査が今出てきているのでコンフュージョンがあるから人によってはまだ説明されない産婦人科の先生もいらっしゃるかもしれません。ただ今大きなムーブメント、婦人科系のがんのムーブメントがあり、すべての70歳以下の、卵巣がんになった方をすべて検査をするという動きがあります。で、
because the technology, it's the technology. And we understand that. We live in a world of technology, and as the technology gets more and more familiar, the cost goes down. That's why the companies that advertise on the TV, 23andMe, right, or this type of thing, I mean, the cost is reasonable for people to do it now.
そのムーブメントは全てテクノロジーがベースで、やればやるほどどんどん安くなっていくので、将来は200ドルとか250ドルで卵巣がんの、遺伝子検査ができるという将来もかなり見えてきています。
Sorry, then quick, do you have any recommendation of the counselor?
Yeah, we could, if you
すいません、アメリカでもこの辺の大きながんセンターには全てジェネリックカウンセラーがいますので、そことまずは交渉して自分たちの家族歴を言って、そこからじゃあ当然保険が何ですかって聞かれると思いますので、そこからお金もしくは初めはいらないかもしれないし、で先生の関係もあると思いますので、一緒の方から一度探ってくださいということですね。
I also have a question about screening.
Can you say it in Japanese too?
Okay, so I have a question about screening as well. Like these ladies, I had a mastectomy last year, less than a year ago, and I had reconstruction and I just finished all the treatment. And I've done mammography, ultrasound, MRI, and genetic testing, a full set. But now, going forward, I still have my own right breast. I want to be as diligent as possible to do the screening, meaning I'm going to get biannual screening as opposed to annual screening. But I also don't want to be exposed to too much radiation. So what would be the best way? Should I be doing mammosono every 6 months or alternating, or include MRI somehow? And what about my left breast? I'm not checking the left breast right at this moment, but what if something develops under the implant? So what would be the best way to move forward? Now in Japanese, right?
Yes, please.
私皆さんと違って全摘を去年してまして、後でお話をさせていただきますけれども、左胸の全摘を再建してます。でそれまでに全部マンモも超音波も MRI もジェネティックテストも全部やったんですけれども、この先右側が自分の胸が残っているので、できるだけ半年に1回とかテストをやりたいんだけれども、このX レイにやっぱりさらされるのも良くないんじゃないかと思いまして、どういう頻度でどんな組み合わせのテストをやったらいいのかという質問をさせていただきました。
Okay, so obviously I can't answer specific questions without all of your records and your history and so on, but what I'm going to say is general. First of all, when you have a mastectomy, you don't need mammograms on that side anymore because the breast tissue was taken away. Any problems that develop typically are very superficial in the skin or just under the skin. As far as the other side is concerned, you're right. You want to really step up the screening and be more diligent, but you don't want to do more than you need that has radiation exposure. So typically, in a situation like this, we'll recommend mammogram once a year, and then 6 months later, additional testing if the breasts are dense. And sometimes we alternate, 1 year ultrasound, 1 year MRI. So you're always doing something every 6 months, but the mammogram is only once a year. And when there's no BRCA mutation, I think it's hard to say to do annual MRIs, so it's every other year, alternating with ultrasound in the 6 months. And that's a pattern I use a lot, and I like it a lot, because it leverages all 3 tests.
最後のクエスチョンとなりますが、彼女の夏代さんの答えに対してシナベル先生は、よくわかります。すごく検診はしたいけれども、あまりにも放射線を浴びたくないという気持ちの中で、1年の中で、マンモグラム6ヶ月後には、ソノグラムをやり、それを全て1年ごとにやるのが一番いいんじゃないでしょうか。MRI については、ブラッカ1の証明がないので、遺伝子がない場合はやる必要がないのではないかと先生はおっしゃっています。
Dr. Schnabel, so you will be able to give us the name of the doctor of the hospital where we can do that with insurance there.
Right, exactly. I'm going to give to Mikiko the contact information for genetic counselors that you can see, and they will start that process, take the history and so on, and always make sure about the insurance coverage as well.
不安に思っていらして、その遺伝子検査を受けたい、私たちが
家族が日本にいる場合がすごく多いですから、がんになった家族に受けてくださいというわけにもいかない場合も多いと思いますので、不安のある方で遺伝子検査を受けたい方、シュラベル先生の勧めてくださるお医者様を、病院を紹介してくださるということなので、その情報に対しては BC ネットワークの方から皆様に後日お渡しできますので、ご利用ください。
Thank you very much. And thank you to